before fiscal year 30 on that one. We're also looking to modernize the healthcare infrastructure. So really, the measure for that one was kind of tough, but it's really just looking to make sure that one provider or hospital purchases at least one modern equipment under the RHT program each grant year. So really trying to build out the infrastructure across the state. And then an increase in the number of mobile care units across. Again, 1 unit by each year by 2030. So much like Milliman has already walked through, right? We're really encouraging innovation and partnership in this RFA. We are looking at ways to, give more points to people who are doing collaborative partnerships and local providers. We're definitely looking at higher points for individuals who are current providers in the community. And when I say providers under this fund, that's really the gamut of providers, right? It's healthcare, from community health workers to physicians. Keep in mind, this is a cooperative agreement with CMS, and I know we've mentioned it, but that really means that they're involved in a lot of the decisions and the final approval of large projects. So we will be working with them on any multi-year projects and large purchases for their approval. Excuse me. And then really establishing priorities without limiting it. The same thing as Milliman, right? We've been working with them, just trying to make sure that we're meeting communities where they are and creating an RFA that allows communities to apply where they're at, and we're not excluding anybody in this process. And then the timelines, I'm not going to go over because we've been over them already. They're the same. We've been over them ad nauseum.
You sure you don't want to go over again?
We don't. And then under questions, I just wanted to, before we get to questions, a couple things that were asked earlier. We are planning a couple technical assistance webinars. Those will include walking you through our application, how to, if you need to add fields to the documents, that kind of thing. We are playing. Evan Hodges, I think, is on the call. He is our new management analyst, and he is actually going to create some videos that walk you through filling out the documents, and we'll have those posted online as well as we'll post 2 live webinars. There's Evan. So to answer your questions and support communities who haven't maybe been through this process so far. Is there anything else you could think of that would be helpful for us to do? And I would highly recommend you all, please read the CMS questions and answers. Some of your housing questions are answered in the question and answer document. It's on our website. And it very specifically, if you control F and do housing, you'll get all the questions related to housing on there. Anything else you guys can think of that would be helpful from our team to ensure that you have a successful application and a successful project?
I have a question. Nancy Bowen, population health software, does that fall underneath this?
It does.
Okay, thank you.
You're welcome.
I guess one thing, Marcia Turner, is if you're buying the tool you're going to use in a program through this, but the program itself is funded through something else, the budgeting piece will be something that, like, how do you?
So what we're telling people is pick the bucket that the majority of your project fits within. And then just apply once for that and include your technology equipment in there. If we need to, yeah. So you don't have to do a piece of equipment here that allows you to do something over there and have 4 or 5 different grants going at once.
I'm just wondering, as far as the sustainability part, we know Workforce Pal is going to be coming. So one of the software things that we would be interested in buying, because we have to do all the tracking through all of those like CTE programs that are healthcare reliant, if this is something that would cover that software as well, because it's part of your sustainability for continuing on the tracking. It also helps you guys with your reporting, but that's how many of those students, what those ranges are, if they stay in that field, all of those things within that first year.
Stacy Weeks, so I'm gonna make sure I understand your question. Are you asking if we can use the Flex Fund for technology software? I think we'd rather that come out of the RIT or some of that strategy, only because it's one-time funding. It's not intended to be ongoing. Now, if someone says, hey, we just need to be able to purchase this one time, the first initial cost, the subscription is expensive, blah, blah. But ongoing, we think, our revenues can cover the membership annually, right? That's different. Then that's a one-time ask. That's easy. But I think we want to be mindful of if they can really cover those costs ongoing. Does that make sense?
Okay. Yep.
Yeah.
And I have one question. Again, this is all new to me. If we put an application in, in the flex fund, and there's a transport vehicle and there's three telehealth machines and several other things. If there's something in there that the committee who is reviewing this says, I don't like that, does that eliminate the whole issue? Or is it, do you guys come back and say, you asked for 1.7 million, we're gonna give you 1.32 because we don't want to give you a ban or whatever the situation is?
Yeah, so the review committee, they've decided that you meet the minimum levels for what it would work with the recipient. There's always a negotiation with recipients in the final process. So there may be an opportunity to say, that incentive payment is way too high. We'll only fund you at this level. Same thing on the other one or on this one. Like we won't give you your justification for 2 mammographies didn't make sense, but we'll give you 1 mammography issue.
Okay.
Right.
Yeah, on the RFA, we have the opportunity to, go back and forth with you and make sure that it meets both of our.
Thomas on the phone, I don't know, or group, say it, I'm just sitting here, say you see 10 applicants all put in for primary care bands, and we all have different vendors. And so we're going to wait for the state to coordinate so we can lower the cost, so we can go in and purchase a joint agreement. So we can lower it and say it's $1 million per vehicle, but we can get it if we just come together, 500,000.
Like, interesting.
Or is it just we go with whoever we want as a vendor? Because I can see us if we're trying to partner along,
Right.
it's going to go longer, if we partner together on some of these bulk purchases, we might get better deals on stuff.
Yeah,
If we're all
Maybe
looking for the
that-
same thing, so.
that's where like the review committee is like, hey, we have these 10 applicants, they're all asking for the same thing out of the same vendor. Let's contact them and say, hey, how about you guys go together?
This is Stacy Weeks. I think that's why we really want to encourage, especially counties and regions to work, or if they can, right, to really work together to come forward with ideas that they have found the best deal. And obviously we can help with that, but I think it's helpful if they've done that. And maybe we think about in the scoring, if you come forward with a regional partnership purchasing agreement, how you're going to share these new opportunities where you guys can all afford the ongoing membership fees or whatever it is, the maintenance and things together, so that we are only covering that one-time purchase and it's a regional share. That maybe we're rewarding and scoring those folks higher. Yeah, so we really want to encourage that. I know that can be challenging, but I think it's what gets us a better deal long-term.
We're here to join in that conversation. I think this, out of the different pillars that we've lined out, this is the one where you're going to be able to see the most collaboration. I'm
Yeah.
thinking in terms of similar to what you're saying for like an EMR purchase. One of the big problems that I see when they need to have is rural hospitals, rural clinics can't afford fancy EMR. It doesn't talk to any of the bigger hospitals. So we're stuck, you'd be shocked at how many things I still have to fax and receive by fax. It's crazy.
So sorry.
It's
Not okay.
So I can see purchasing an EMR as a group, I think about rural health partners going in as a group and how many licenses can you get. But it's gonna be a big bill. Like, these things aren't cheap. I think it's $10 million or something to get a license, so. But I think that's where, it can be weighted that, but 7 hospitals are gonna get to use this thing. I think that's really important to think about. I do have some concerns about the sustainability because I don't know what the ongoing licensing fees are. And so, and having been through EMR transitions, it's the worst. So you don't want to do something for a few years and then have to switch back. So, just comments from the ground, I guess.
This is Stacy again. I really appreciate that because I feel like technology is the bane of all of our existence sometimes, even in our world too. There is the RIT, right? The Rural Health Information Technology Fund. So I think what we need to think through is what do we want to consider one time? Because this is a limited, flex fund. And the RIT grant, is it worth more, Melinda? More funding with
No, I think the
EMR?
flex fund actually
Is the
has more
flex fund
funding.
more? Okay, so I think it's important for us to maybe look at that too and think about what's the difference between that and to make sure people are taking advantage of the right pots of money. But the RIT grants are really designed to help with EMR, Cybersecurity, like if folks want to come together, sharing of data so they can better do population health management, right? The things that we all wish we had the resources to do. So I think, Dana, maybe we need to take that back and think through the technology pieces. Yeah.
Maybe to Dr. Warco's comment, I was speaking with a hospital CEO just the other day, and they were asking about EHRs. And there are some limitations on how much money we can spend on EHRs. There are some caps in there. But I asked a simple question, are you ready for a transition to go from one EMR to the other? Oh, no, we don't want to do that. So my next question was, well, are there any modules that your current EMR will allow you to upgrade so that you can not send faxes anymore, so that you can have all this interoperability? And through a process of questioning, they found that, oh yeah, we can do that. And so maybe a full EMR transition is not needed, but if the current EMR will offer more modules that will allow for interoperability and the communication that maybe wasn't affordable before. Sure. This might be the time.
Or even if you've had, sorry, this is Amber Dinelli, even if you had a transition where you start with like 2 hospitals in a system, because ideally you'd want it to be something like, I mean, Utah's like a model. It doesn't matter where you're at, they're all on the same system, whether you're University of Utah or Intermountain Healthcare. And so maybe we start with 2 hospitals, we've got 5 rounds, then the next 2, and then the next 2. And you do it based off of who's ready, you know, and transition them, because if you Band-Aid it, we're still going to be, you know, in 31, we're still going to be like, you're not on this one, you don't communicate with this hospital. And largely rural hospitals transfer patients to our big hospitals in Las Vegas and Reno and Carson. And so if you don't have that transition record, you haven't made any gains. And so the gain would be to make everybody connected. And the only way to do that is maybe process it out. Just a thought.
So, so that was kind of one of my questions there, is within the RFA here, it talks about, you know, potentially doing phased approaches across multiple years, and wondering if that is developed in one application, or if you write a phased approach, such as what you described, do you have to write multiple applications for each of the 5 years as you build that phased approach? Because it talks about also writing it in this initial and to talk about that. So just something that I was curious about as I was reading it. And then my other question is, one of the things that caught my eye in here, and it goes back to our conversations around partnerships, larger health systems coming into smaller communities, is it talked about a transparent affiliation terms approved by the steering committee and Nevada Health Authority. And I'm kind of wondering what those particular guidelines are. I didn't see them in here anywhere, or if they have been developed, if it's something that's being developed. That was just on page 3 of the RFA when I read it. So, not that I don't love that idea. It kind of goes back to a lot of what we were talking about. What does that look like? Letters of commitment, et cetera.
Oh, sorry, having another fire over here.
No,
Thank you, Lisa. For the record, I just heard what you said. It came to me. It's my fault. So that's in there because we need something
Yeah.
to show. It doesn't have to be an MOU. It doesn't have to be completely, fully fleshed, but there needs to be something, right? Yeah.
Absolutely. And I
Yeah,
think an
sorry,
MOU or a letter of
Yeah,
commitment is great.
yeah.
I just happened to see this affiliation terms approved by, and wondering what that looked like, if there was a specific rubric or specific items that were being looked for under that. I had written later on in here about zip codes and areas, which we talked about in our last conversation as well. So, but
Sorry, read the last sentence. Affiliated with what?
affiliation terms approved by the Rural Health Transformation Steering Committee and the NBHA. That was on page 3.
RFA. Yeah. Oh, okay. Let us look at that and go back with our consultants and make sure we flush that out. I think that's a good point. Yeah, to make sure it's clear. There. Thank you.
Yeah, and then I
It's
love
always
it.
helpful to have fresh eyes. Because, you know, when we look at it all day, you don't.
Yeah.
Right.
Yeah.
And then, another note I had, on page 14. And it goes back again to this rural healthcare, like maybe a little bit of background on the work they're already doing in the rural communities. And I
Yes.
didn't really see that in the narrative anywhere, but, asking for some inclusion of what is your history of serving the
Right,
population
relationship, yeah.
and those relationships as you're.
That's good.
This is Marcia. Can I ask a question about just timing and back to the big timing question, but I know there's the time to spend the money and draw it down and commit it and all that, but what is the timing of when you have to submit the year 2 application that you're gonna want some stuff to show for the year 1?
60 days prior to close of this budget period. So what's that going to be? July, August 30th.
Yeah, August 30th.
August 30th, I will have to submit our continuing application.
So the progress into all of the deploying of funds and then any low hanging fruit opportunities from the grants, I think that's a good thing. I know there will lots of.
I have a question. Nancy Bowen, I'm looking at the scoring rubric. Under 3, budget narrative and budget plan, says maximum point at the end of the blue section. Maximum possible score for the section is 15. However, when you add up the maximum points in the second column, it's 40. So I'm a little confused.
Oh, yeah, that's probably our math mistake that we need to.
I mean, 40 points for a budget, I have to say, is big.
Yeah.
So, okay.
I mean, yes, we do want to prioritize, the budget and the importance of it, right? Like,
Yeah.
having that, I don't know.
I mean, I'm okay with, we're good with finance, but it just seems like a lot for a grant.
Yeah, we were trying to stay within the parameter of 100 point total.
Yeah,
Make it, easy, yeah.
well,
We all don't like that.
yeah,
Yeah.
it's like 25-point difference between there, so
Good point.
figure it out. If we can figure it out, yeah.
I circled that too.
It's like, usually here's a big
Yeah, yeah.
In my experience, it's always been around 10, 15 points of all the federal grants that we've done, which seems odd to me because you're right, Melinda. It is exceedingly important that they can spend the money properly and, do it within the allowable costs of the federal government, the CFR, but.
Yeah, I think because we have, 50 points for the project narrative that
Yep.
has those 4 components and then 40 points. There's only those 2 components really for these RFAs. So I think that's why.
Okay.
This one also has some other letters of commitment, et cetera. Noel Schnee, for the record, it also, within the scoring group, it talks about letters of commitment, and then there's, MOUs and some other ways of phrasing that earlier in the narrative. So maybe just some consistency as to what that looks like, how we're showing. Do we want MOUs? Do we want letters of commitment? Do we want, what does that look like?
Give options.
Or both, yeah, depending on the need, I don't know, but that consistency.
Or MOA,
Memorandum.
memo of agreement.
Memorandum,
Yeah.
of agreement, that's the new.
Maybe still 3 at some point.
And what do you guys think about,
Until you get to BA.
rather than allocating 5 points to that, what if it was a pass fail for the applicant that, the applications where that was necessary?
I agree.
I would agree.
Not every application's gonna be.
Yes.
Right, yeah.
Okay.
Or it's bonus because we want that collaboration, so maybe they don't need it, but if they have memorandums of understanding or agreements within their area with multiple providers, because you're showing that collaboration. I don't know, maybe weight it a little bit heavier.
Becky
That's an
Bailey,
emphasis.
I just want to say, I think that our rural providers are getting bombarded with requests for letters of support right
Yes.
now. And I don't know if they're signing all of those and if they're really understanding what that means in terms of the application. So something a little stronger than that, like an agreement.
Yeah.
It might be worth more.
look at
Great.
MOA.
Yes.
Stacy Weeks for the record. Just want to make sure we give enough time for people to get those MOUs or MOAs. So I don't know how long this one's gonna be posted, but want to make sure we give people, because that takes time with attorneys and.
Based on this conversation, I would suggest that we mirror what we just talked about and just do a 30-day, posting for that first batch. And then come back and do another posting.
And if you're concerned about memorandum, then do letter of commitment. I do like the letter of commitment. I've done that on other grants.
So that lines out exactly
Yeah.
what
You're
each
like,
party's
you'll do
doing.
this, we'll do this.
We're attorneys, I think.
Yeah, that's basically
I
it.
say that.
So letters of memorandums of agreement stuff, like our tribe requires legal review and then a council. approval.
Yeah.
It can take 2
Yeah.
months sometimes. So
Yeah.
letters of support maybe easier on these short ones, so these short.
And they're either like one paragraph or
Yeah.
page.
Yeah.
Is everybody ready to move on? Enough of the flex? Okay, thank you again for the good comments and suggestions there. We'll move on to item number 12, which is informational item. This is a presentation on the RHT reporting process, and we have an expert joining us on video today. This is Maddie Lope. She's Chief Biostatistician for the Health Authority. Maddie, can you hear us?
Yes, can you hear me okay?
Yes, thank you for joining us.
Yeah, of course. Good afternoon, everybody. I'll make this a little bit quick since it's been a busy afternoon. But I just wanted to talk about some of the data reporting requirements for the RHT. So to remain eligible for funding, all awardees must submit required reports to CMS, both annual and quarterly reports. So for the Nevada Health Authority, our first annual report will be due August 30th, starting this year, and then each year after. And our first quarterly report is due November 29th. And then about every quarter after, give or take like 30 days after the end of the reporting period. So on the next slide, this, I believe Jason already went through a lot of this at the very beginning of the meeting, but within each of the 4 initiatives, there are required metrics that we will be reporting on. The main thing that I want to flag for these is just that a lot of these will come from different data sources. So some of them, for example, in Initiative 1, the death rates will come from vital records and death certificates as they're reported to the state and the Department of Human Services. Initiatives 2 and 4 mainly are going to be metrics that are going to be collected through grants that are awarded funding. So that's a lot of that is data that doesn't currently exist that we will be collecting as the initiative goes on. And then for Initiative 3, a lot of that is going to be coming from initially probably Medicaid claims data that's reported to the health authority, and then ideally with expansion to our all payer claims database. And actually on the next slide, you will see some of this. So on the left side, there's 3 resources that are linked here, 3 dashboards that are on our Office of Analytics website that are public facing that already include some of this information. So the first one, the Behavioral Risk Factor Surveillance System, includes information on heart disease, which was called out in that previous slide, but a lot more information there, just like general health trends and health status. Leading causes of death in Nevada has the top 10, I believe, leading causes of death statewide and by different county. And then same for telehealth utilization. A lot of that is pretty general information of just total telehealth claims and services. But we do have the intention of expanding that into a little bit more detail to really give an idea of what that utilization really looks like, what services people are getting. But then over on the right is upcoming resources that we're working on. So like I said, a lot of this is going to be coming from Medicaid claims, and then as our APCD is stood up eventually to see kind of the bigger picture, not just Medicaid, but all payers. But there will be 2 dashboards coming up. One of them is specific to the RHT metrics that we're required to report. And then one of them is a provider network dashboard that I wanted to highlight. It's going to have a lot of information just about what our provider network looks like in Nevada by different regions, counties, the ability to drill to rural, different provider types and specialties. So all of that information will be public facing. And then, like I mentioned, a lot of it will be grant specific data collection. Next slide, please. So this is the last thing that I wanted to kind of talk about, and this is just a screenshot of like a rough draft that we have for the RHT dashboard. Like I said, all of this would be public facing, and really the intention is for you all or anybody from the public to be able to go in, see what's the status of each of the initiatives, the metrics, how has that changed over time. So all of this is mock data. This is a very rough draft, but just wanted to give a visualization of what it's going to look like. So you can see in those two boxes kind of at the top, or I guess a little under halfway, you can filter between an initiative and then the metrics within it. That will show the trend of where we're at compared to what the baseline was or before awards were funded. And then the key metrics will just kind of show where we're at currently, what the goal is for this initiative or this metric. And then, like I said, those dashboards that are public facing and already existing on our website, plus that provider network dashboard will also be linked. So for users to be able to easily navigate between them. And really the goal is transparency and easy access to any of the data to track kind of what's been going on with this. And that's the last thing that I have on here. I would note at the bottom, there's the Office of Analytics reports catalog. That link should take you to our Office of Analytics homepage that has all of our public facing reports and dashboards that have a lot of information, and most of them do have the ability to either drill down to county or region to be able to look at rural counties. And our data request email is also on there as well.
Are there any questions?
This is Amber-Dean. I have a comment just in our areas of Winnemucca and Elko, because they're highly insured areas due to the industries there. I think you also are going to have to look at the reporting of both those hospitals on the delivery rate. Because if you're only looking at Medicaid, you might see small gains rather than the actual gains if you're able to increase the providers in those areas for OB.
And I'll also note too that Medicaid claims is kind of one of the big data sources that we have that has a lot of detail that we can't get from other data, but we are through this process and really through a lot of the related initiatives trying to collect as much information as we can. So exactly, the intention is not to limit to just one source where there might be limitations, but try to incorporate and supplement each other with the data that we have available to us.
And this is Marcia Turner. I would imagine too that in as much as data be collected through any of the new tools being used, that would be great to make sure that you have access to that for the whole, research and public health stuff.
Yeah.
If it's de-identified.
So another layer of what's being reported quarterly for state purposes is what you're talking
Well,
about.
I guess I'm thinking like if it's remote patient monitoring and you guys invest in the monitors and a lot of data is being collected to care for that person, there's also a lot of really good rich data to understand, did that intervention change things? Are we, so it sort of helps with the research, the public health outcomes.
Yeah, Josh Cabral, just kind of to add on to that, like we do at CCBHC, we do a ton of reporting. And we're now required to also report non-Medicaid data, and it's a pain and it's a lot. But what we found is that, like looking at some of our crisis stuff that we do, like 80% of the crisis services that we do are not Medicaid. And so when we're really trying to gather meaningful data as to what we're doing and what it looks like and what is needed, if all we're looking at is Medicaid data, we might be falling short in a lot of, but it's hard. Like, I don't know, what what the state can require and how that, what kind of SATP or whatever that's gonna go through, but that's a whole other can of worms, but that's a very, very good point.
Any other questions? And our intention in this is that for these quarterly meetings, we're going to bring reports to you. Want you guys to put your eyes on them, but to analyze them with us, help us understand what you see. These reports, we want you to be helping us all through this. Maddie, do you have anything else to add?
I would just note that data in general is, the intention is to supplement and support the work that everybody does. So, like Jason just said, the intention is to display this information for everybody. But if there's information that's missing or that would be really helpful, we are open to feedback, and, you know, we'll do the best that we can to include and accommodate as much as that.
Very good. Thank you, Maddie, for sticking around for your item on this long agenda.
Thank you.
All right, we'll move on. We're almost done. You guys are champions for sure. We're on item number 13, informational item. Next steps and timelines for the RHT program in 2026 and 2027.
Yes, and this graphic only goes through 26, so apologies there. I just wanted to quickly share with you all a nice timeline graphic that we have on our website that just kind of goes through some of the high points for each quarter of the RHT program. So, of course, the January through March bullet point is, I mean, we pretty much have gotten that. We're still working on hiring our staffing team, though, at the Nevada Health Authority. So we do have quite a few positions that are open that will be posted here soon. And then we also are doing the hiring for the, like, I think 4 positions right now. We're doing the interviews for. So exciting time. And this basically just goes over, you know, the things that we've already talked about with, like, the RFPs and the RFAs and the different dates that they'll be available. And so I appreciate you all, you know, bearing with me as we tried to figure out what the actual date was. But yes, I'm glad we got that clarification. And just to confirm, the slides online are correct. And so that's, let's see, what else do I want to highlight here? Sorry, I know it's late. So I think that, I know. My goodness.
Melinda, do you have a question?
Yes.
Help with that?
Go for it.
Under late 2026, you have published BP2. That's for year 2, correct?
Correct.
So people are gonna be doing applications now in the next 2-3 months, and again in October.
Yeah. So the thing. we
Okay,
really
just wanted to clarify.
Yeah, we really want to hit the ground running, right? Because this year we kind of got a late start, right? It's starting in the end of December, technically. And so for this next budget period, we want to do as much pre-work as we can before that budget period starts the clock then, so that we can get the RFAs out to you all quicker. And then, you know, allow more time for those projects to take place. Thank you.
Can I ask a question? This may not be the time for it. I know there's no supplanting on certain things. So in our situation, I can only speak for that, but we have a hospital district, 5 members. 2 of them never show up. The other 3 all have jobs. And so they have no time to work on applications and different stuff. I have a full-time job as the town manager. I don't have a lot of time to dedicate completely to that. The thought was maybe to hire somebody to start putting the application together and throw some time behind that thing. But would we be able to, is that supplanting if we hire them before we get any grant money? And if we don't hire, if we do hire this person and it's not considered supplanting, can we go back and at the hire date and reimburse them for all the stuff that somehow we're gonna have to find the funding and pay this person to do the grant and the management of the grant and continuing on?
Right. Very good question. I appreciate you bringing that up. This is the right time, you know, this is the group to talk about these things. So with that, we cannot reimburse anybody for any pre-award cost. So anybody, like any cost that you expend before that sub-grant or the contract is signed and executed, cannot be reimbursed under that sub-grant contract. But hiring somebody to help you manage the grant for the sub-award once it's done, is an allowable cost. That would be like an administrative cost, right?
One more question.
Yeah.
So could you hire that person, throw them at a salary or something for till your contract expires on September 30th? And then on October 1st, that new contract has been put into the grant going forward, and then they stop that contract and go to the next one?
So they become the project manager once you get the grant.
Right.
Yeah, I don't know how that would work going from subboard to subboard, because the subboards will have to be separate. There may be some lag time in between the time that your, you know, BP1 subboard ends and when the BP2 one starts. So that could be a potential issue. Like you'd have to find other funding to support that person in between that time frame if you still want to keep them on during that time.
Go ahead.
I was just gonna say, this is Amber dealing, you may very well, like, in between that time, help you write your first. I'll have to see what the team has, but figure out. what-
I think there's a way to solve it. I just
Perfect.
trying to figure out how we can go about it.
Yes, brainstorming, it's important.
All right, Nancy Bowen, one final question, I promise. Admin, you said, I believe there's a cap on administrative direct to indirect costs at 10%. Does that apply to subrecipients or that it just applies to the main primary awardee?
I want to say it also applies to subrecipients because CMS has made it very clear that all of the terms and conditions in our federal award flow down to all of our subrecipients, which in turn would then flow down to your subrecipients.
So it's more seen as a pass-through. It's like physically. Sorry. It's an audit thing. Good to know.
Okay, any other questions on timelines? Done a lot of timelines.
Okay, we're gonna just a super trivial one, but on the invites for the meetings that were sent out for the September meeting, it was September 10th, but it's September 9th on here.
Oh. Well, whatever date it is, your calendar would be the date. So I apologize for that. Mistakes.
So it is the 10th then?
If it's on the calendar for the 10th, then it is the 10th.
What day is that?
So it's Thursday,
Okay.
September 10th.
Yeah, I've only been told by one committee member that Wednesdays are bad going forward, and so try to switch those to Thursdays.
Wednesdays are bad for me too, so
Perfect.
All right, so yeah, September 10th, that is the
Thank
date.
you.
Excellent. Any other questions on timelines? All right. Thank you. We'll move on to item number 14, which is our public comment.
Want me to read the-
Yeah, you're got a much better voice than I do.
So, public comments. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and to spell their last name. I would like to, at this time, please call for public comment and please go ahead and raise your hand if you do have public comment. The first one I have on here is Amanda Kay. Please go ahead.
Sorry, I had to get unmuted. My name is Amanda Kay, last name Kay. Just a couple of quick questions. One is, there was a lot of discussion about Nancy Bowen's suggestion about the 30-day. Did I hear right that was agreed to and that's going to be the way it is? Or is it still this rolling thing until we hear different?
Thank you for that question. Yeah, so we're taking that into consideration at the Nevada Health Authority as we develop the request for application, and that will be released here later this month. So we'll have details in that RFA for you all.
Okay, so at this point, it's up in the air. We don't know.
Advisory. Yeah, this is an advisory committee, so they've given the advice, and we're taking that back to the health authority. So again,
Okay.
we'll have those details for you.
Okay, if I can make a suggestion then, if you do stick to the rolling, please have one of the webinars before the drop date, because that would be extremely helpful in trying to pull together all of the materials that will be needed for the application. Because you were talking about the webinars being between April and August, but the drop date's March 31st. So I don't know how much leeway there is there. And then several of the members were talking about the RFA when I read it, and then talking about a scoring rubric. And I can't find anything on your website about that. Is that stuff that was just available to the steering committee members and it's not open to the public?
That should all be posted online to our RHT meetings page. I did double check that this morning, and all of the meeting documents that were included today are posted there.
All right, thank you. I'll look again.
Of course. Thank you. Next, I have the conference room in Carson City.
Yes, thank you. My name is Demi Gonzalez, Gonzalez. I'm the CEO for the Adoptive Dental Program and a board member for Compassion Dental. I would just ask the committee, I appreciate what you guys talked about today, and just to, on all the regions in the RFA, our programs cover the entire state of Nevada. So, I mean, all the way up to Jarbidge, to Rebecca, to every rural area that we have. So in the RFA, if there is going to be sections where they say, what section are you applying for? Can there be a section that says we cover all rural areas of Nevada? Also, the letter of commitment and the MOU for dental care across. I've been to every single county and traveled to every single town of the state, including Jarbidge. And I'm well aware of the needs in those areas. And in our program, we have rotational dentists. So we may not have a dentist that's willing to be there consistently all year round for 1, 2, 3, 4, 5 years, but we have 170 dentists that participate in our program that I'm pretty sure many of them would be willing to sign an MOU stating that they want to be within the list of providers that will be willing to go to these rural areas at any given time, but not specifically them in general be the main provider for that area. So let's say we look at Tonopah. There's a clinic we can use in Tonopah, but not one dentist is going to want to be there for 5 years. But I know plenty of dentists will be willing to travel there every so often and have that available for those rural communities, to include whether it's Elko or Austin or any of those different areas. So the committee can take that in consideration when they talk about what the application needs to have in terms of, like, it must be an MOU or a letter of commitment, if there can be some leeway on the understanding on that. And then dual entities, our Adoptive Vet treats non-insured veterans, but Compassion treats the uninsured and the Medicare patients in around the state of Nevada. So that will be something that hopefully the committee will be able to understand how we do that work. Our whole program is structured around being self-sustaining. So while the Flex program talks about being able to garner funds to get technical devices to enhance what we do, there are areas in dental that make it a lot easier for dentists to go to rural areas and complete full mouth restorations without having to go back and forth from city to rural areas, and that's what we're looking at. So when we do apply for this, if there's a committee member that's willing to come to our dental clinic in Reno It's the only one in the nation that we have that primarily is for what we do. We'd love for any of the community members to come there and see what actually we do and how it works around all over the state of Nevada. But that's a consideration for you and just the rotational dentist. But thank you for today. I appreciate it. There's a lot that I learned today, and hopefully we can get the RFA out there as soon as possible. And I agree with the lady prior to me to please get the trainings out there as soon as possible. Thank you. I appreciate it.
Thank you for your public comment. Next we have Zoe.
Hi, yes, I don't know if you guys can hear me. But Zoe Houghton for the record, I was just asking if there was any clarification on how the RAP funds would be coordinated with the SHARP funds. I know there was a meeting earlier today regarding the SHARP program, but and they kind of target similar goals. So just curious how those will be awarded in coordination.
Yeah, thank you, Zoe. I appreciate you bringing that up. So the SHARP program, for those of you who are not familiar, came out of SB5 from this 2025 special session. It's the statewide healthcare access and recruitment program. And that program is specifically targeted towards building the sustainable infrastructure and healthcare in Nevada for Nevadans, right? So we don't have to travel long distances or outside of the state for these specialized services or healthcare in general. The RAP program is more targeted towards obviously rural Nevada, right? And serving the 13 rural counties designated as rural through the Health Resources Services Administration. And so the RAP program is more targeted, I would say, whereas the SHARP program is more statewide. The SHARP program will come online starting this mid-July this year. You'll see an RFA come out for that program. But these are very separate programs, and so they will have very separate specific requirements outlined in the RFAs and the RFPs associated with them. Thanks for your public comment. All right, any other public comment? Oh, I got one more. Paul, please go ahead.
Hey, good afternoon. Paul Melendrez, MELENDREZ, Esmeralda County. This is a real quick one. In the scoring rubric for the RFAs, is there any additional points for it truly by definition frontier county as opposed to rural county? As you know, Esmeralda is the epitome of frontier. So are there any additional points currently, or would that be a consideration?
Yeah, thank you for your public comment, Paul. Appreciate that. We can take that back. We did talk about that on the agenda, so we can definitely take that into consideration. Thank you. All right, any other public comment? Okay, seeing none.
Good. Close it up.
Sure.
Well, just in closing, before I call for adjournment, I just want to share my gratitude for each one of you as committee members and those that are still online with us. Your commitment today, 4 hours, I mean, that's quite tremendous. And we only had one 5-minute break. Thank you so much for being willing to step forward at this time with this wonderful project and to give us some guidance and counsel. We take it seriously, and we look forward to continuing to work with you as we build our team here and as we make this program something really that we can brag about for years to come. So thank you very much. With that, are there any other comments that we need to have?
I just want to thank you guys.
That's
You guys been doing
yeah.
so much
That they
work
did.
all the way through.
Yes.
They're like the
Agreed.
mighty 3 and 4. There's
We
five
follow
of them now.
Melinda. We follow Melinda. Well, thank you. And if there's nothing else, I'll call for a motion to adjourn. Thank you very much. Thank you online.
Thank you all.
Jason, do we take these? Do we leave